Welcome, everyone. We're super excited to have you here for the second session and final session of this Rooted in Trust research webinar series. We've been showcasing some of our latest research that have come out of the Rooted in Trust project at Internews. And today we're excited to be launching and presenting a research piece that we've been working a lot on, which focuses on the preparing information ecosystems for future health emergencies. Today we're joined by Rocio Lopez, who is the Community Engagement and Accountability Advisor for the Rooted in Trust project at Internews. We also have Sarah Hess as a guest, who's the Technical Officer at the Epidemic and Pandemic Preparedness Unit at WHO. And we have Dr. Michael Gubay, who was the researcher and program manager of the Rooted in Trust project at South Sudan, as well as myself, who am the lead social scientist at the project. So I'm going to start introducing the research a bit and how it was produced, and then Rocio is going to lead us into a conversation and discussion into the findings of the project. So first of all, why our focus on preparedness? So as we know, there's an increased likelihood of future health emergencies due to factors such as zoonosis, and there's also a reemergence of diseases that were previously under control. This is all due to various factors, including environmental stressors, political instability, challenged health systems, all of which is increasing the likelihood of future health emergencies. Additionally, as a society, we've all lived through the devastating effects, social and economic impacts of COVID-19 pandemic, which were partly intensified due to weak preparedness. So all of this has led to a collective reevaluation, which I'm sure a lot of you have been exposed to, prompting discussion amongst key actors about amending international health regulations and new agreements for pandemic preparedness. Understandably, a lot of this conversation has centered around strengthening health system capacity and promoting a One Health approach. And while that is very important, we at this research wanted to emphasize that information ecosystems and information are just as important, are also very important factors of a health emergency preparedness strategy. We know from our work and from research that in a health emergency, when there are flaws in the exchange of information, this greatly contributes to the rise in misinformation and clear health guidance and adverse effect on individuals and communities' health, all of which drives mistrust in healthcare actors and affects the effectiveness of a health response. This has been acknowledged by recent declarations such as the UN General Assembly Declaration on Pandemic Preparedness, which acknowledges that there is a need to focus on addressing infodemics, health misinformation and disinformation, as well as hate speech, as part of this preparedness sort of discussion. Overall, we know that robust information ecosystems improve health crisis response by providing timely, accurate, and widely accessible information, which influences decision-making and facilitates coordination. This is the next slide. So given the importance of information ecosystems as part of preparedness, we thought that it was important to ask ourselves and get some evidence on how do you actually prepare and strengthen an information ecosystem prior to our health emergency. We know it is important for information ecosystems to be resilient and strong before the emergency actually hits, but how do you actually strengthen those ecosystems? And so it became imperative for us to understand what information ecosystem preparedness means for different actors, and what are the challenges and strategies for its implementation. And that was sort of the core that guided this research. The next slide. As you see, we take a purposeful information ecosystem lens and approach. We use this as a more holistic alternative to one-way top-down information practices that focus sometimes only on access to information, For us, information ecosystems are more representative of real-life information exchange and trust dynamics. Information ecosystems are the combination of information providers, channels, platforms, and tools for accessing and sharing and creating information. What's key here is that any entity, organization, or individual, not just the traditional ones, can be an actor in an information ecosystems. And these ecosystems are dynamic, they're variable, and they are highly context-specific. They depend on the specific community that we are talking about, the language that they use, the risks, and other factors. We emphasize a lot the two-way dynamic and process of information ecosystems, as actors are emphasizing that actors are continuously generating, sharing, and consuming information for their decision-making. So we take this sort of network approach, and through that, we reach our research objectives, which is the next slide. The next slide, please. Thank you. And so this is the basis. No, the previous one. This is the basis of our research objectives, in which we set out to examine how information ecosystem preparedness from a network building perspective. So as you see, we focus a lot on the existing relationship and coordination between and across actors when it comes to the provision to the information ecosystem. And our three objectives were, the first one was to deepen our understanding of the challenges and gaps faced by information ecosystem actors. Once we had identified those challenges, we wanted to identify obstacles that were hindering cooperation for strengthened collective action between these actors. And finally, since we had identified both the individual challenges and the obstacles in the relationship between actors, we identified strategies and approaches and interventions that could help us actually prepare and strengthen the resilience of an information ecosystem prior to a health emergency. How did we do this? So our methodology consisted, next slide, thank you. Our methodology consisted of our qualitative approach. We conducted 40 key informant interviews in DRC, Mali, and South Sudan. And we interviewed a variety of actors. So we interviewed media entities, we interviewed humanitarian organizations, community actors, and also a variety of health system stakeholders. So we wanted to get really sort of a holistic perspective in those three contexts. And next slide. And we will jump, Rocio will present in more detail the findings, but what's important to emphasize here is that overall, what we found is that information ecosystem preparedness is about the real dialogue, cooperation, and exchange of information that is taking place between actors, and not just between the traditional actors, but between all actors that are relevant to a community. So what we saw is that the objective is that when the health emergency is actually taking place, communities need science-based information that's coming from health agencies, but this needs to be combined with the latest contextual knowledge that is held by community engagement and civil society organizations, and this must be discussed via two-way communication channels that are preferred by communities, which tend to be local media or, again, CSOs. So what's key here is that those different actors need to be able to share and cooperate with each other before the emergency. What about building and maintaining those relationships and networks across actors? And our findings are going to go deeper into how that can actually be carried out. So with that, I pass it over to my colleague Rocio, who's going to give us a bit more detail about the findings and is going to invite our panelists to provide some examples for discussion.
Thanks so much, Alejandro. Thanks for this intro. And yes, as he was mentioning, we have aimed at understanding how we can prepare the information ecosystem, also understanding a bit more this multidimensional nature of information dynamics and the wide range of actors involved in producing, sharing, and consuming information during a health emergency. As such, we need to consider all the different aspects that contribute to the success or failure of health actors, information responders, and health communicators, a bit on what he was mentioning of strengthening these relations, but trying to understand what are the gaps, in capacities, in systems, in processes and structures, and also finding relevant solutions that are community-led and sustainable in time. And these, we consider, if we have this information ecosystem preparedness in mind, this will ensure that all actors and networks can function collectively on the information response in the face of health-threatening events, as Alejandro was mentioning. So all that technical expertise together and coupled with the contextual knowledge of local and community actors can actually result in access to accurate, relevant, and timely information by communities during the emergency. So just very quickly here, Alejandro mentioned that we mapped all the different gaps, the different barriers among all the different actors in the information ecosystem. Obviously, there's many more, and also very specific to the community that we may be targeting, but we focus on these four key actors: humanitarian organizations, community actors, media entities, and health system stakeholders. And we mapped what were the barriers and the gaps among themselves in terms of engaging with one another, ensuring access to accurate, timely, and actionable information that they could use from their very specific mandates and roles, and also what was preventing them in terms of acting on that information and supporting the collective information response. So yeah, we mapped these, the very specific relations, and you can actually check those in the research report. We're not going to go so much in detail into these very specific relations because it would take a long time, but we really invite you to go and check them and see if there's any specific relation that you're interested in. But today we're gonna discuss a bit more the common areas of concern and the recommendations that emerge from all these analysis of the challenges and barriers for preparedness of the information ecosystem, where we also see a need for intervention. So we will discuss the areas of concern and the recommendations that. The recommendations come also from the key informant interviews, either as a suggestion from the key actors that we interviewed, or either as practices that we identified that were actually taking place and were working properly to bridge the specific gaps. So the results are grouped around the four key elements of the preparedness framework, which are governance and coordination, information management and planning, capacity building, and finance. We firstly did so intentionally as a means to also embed the conversation of information ecosystem preparedness into wider preparedness conversations. However, also as we were analyzing the results, we realized that all these elements were actually there, and we assume it was not a coincidence. So now very quickly, I will start exploring the first area of concern around governance, coordination, and collaboration. We found that there's limited leadership and lack of coordination structures fit for preparedness, especially at the local level. So here, coordination is mainly emergency bound, and this makes it difficult for organizations to work towards filling essential gaps before the emergency, and that affects their readiness when the emergency hits. This also prevents them from working collaboratively towards communication efforts that can support prevention, or, for example, like wider also health literacy efforts, or generally emergency prevention efforts. Just quickly reading, I want to quickly read a short part of this quote from a CSO in Mali. This interview states that actually when COVID started, only a small circle of international NGOs could participate in meetings. And there is thus, like, they realized that there was a huge need to open these meetings to smaller organizations, because otherwise these smaller organizations, which are all over the territory, get ignored. And larger organizations, international NGOs, take a lot of time before they can act. This is actually a very good illustration of how the second point, limited coordination structures, there is a limited coordination structures that recognize the role of community actors and local media and incorporate them into decision making. As we can see, a lot of times CSOs, local media, obviously, but also even smaller NGOs do not have the access to these coordination spaces, and that also affects their ability to get adequate information and act accordingly. There's also an organizational and management culture that prioritize top-down approaches rather than community engagement throughout. So this means that community engagement is rather perceived as an activity that supports information interventions when the emergency hits, but it's not considered as an approach that starts with allowing community representatives being at the table where decisions are made, and also for in planning stages. And finally, there is a lack of long-standing collaboration with local actors that's to support systems and capacity building, and that ultimately impacts the ability of local actors to react when the emergency breaks. In terms of recommendations for this first set of findings, we have that information ecosystem preparedness should be integrated into national strategies for emergency preparedness with a focus on local information ecosystem. So this means that strategies should consider the different actors, including local media, CSOs, local health workers, vaccination teams, or community health workers, and consider them as adequate entry points to the community who can actually support broader preparedness efforts from the perspective of communication and information. There's also strengthened coordination among information ecosystem actors should be considered as complementary to RCC coordination. And this means that we should not remain having conversations among RCC practitioners at national level or health system level or in humanitarian organizations, but actually allow other relevant actors to be part of those conversations, to be part of coordination, have them in the loop of decisions, and also make them allow them to contribute within these fora. Again, community engagement should be considered as an approach, not as an activity, and RCC actors should ensure further engagement with private health service delivery, faith-based health centers, and other sectors such as education. I think I missed that point before, but there was also, we identified that there was also a significant interruption in the coordination between more like public health systems and private health service delivery or faith-based health centers in terms of communication and information, making it very difficult for them to coordinate, even if they were serving the very same community. And finally, there's internal coordination among health system stakeholders for RCCE needs to be strengthened at the local level. We will see more of this point in the next section, as healthcare workers seem to be highly disconnected from information or communication efforts emerging from more national health system RCCE structures. Now I'm jumping into the second area, second common areas of concerns in the second element, which is information management and planning. So in terms of data sharing and information systems, we identified that there's inadequate collective systems for data sharing around community information needs and misinformation or social listening. as a lot of times we see that humanitarian and health actors or health system at national level keep on working with their own data sets and driving their own interventions. A lot of times they may actually also share it among themselves when we're talking about like health actors which are in a more technical supporting role to Ministry of Health. But this data is not made accessible for other type of actors, especially at the local level. We mean more in terms of media or in terms of civil society organizations, also in terms of healthcare workers. So this makes it difficult for them to adapt in a relevant way to the local needs and respond also in a way that is contextual. This, for example, was especially voiced by frontline healthcare workers who struggled to find responses to the rumors shared by many of their patients. So a lot of times they were not prepared to in advance, or they didn't know about the main concerns being shared in the community or what they should respond, because even if they knew, a lot of times those concerns extended their clinical expertise, because they were maybe more connected to public health measures that were taken at the national level, or they were discussing availability of vaccines at the regional level, or any kind even of expressions of frustration more connected to geopolitics, etc., etc. So these were a lot of times concerns that healthcare workers and frontline workers were unable to respond to, making it obviously like more open to further misinformation. In relation with this, also healthcare workers and health service managers or hospital managers expressed that there was an inadequate way to share information internally within a broader health system about the decisions made during the health emergency, what made also very difficult for them to communicate that at the very community level. And this is obviously especially important if these communities or these hospitals serving those communities are in isolated areas, as they may be the only entry points to community information about health. Then in terms of planning, we identified that there was an inadequate mapping of information ecosystem actors for preparedness, especially at the local level, and this led a lot of times to inefficiencies in information responses when the emergencies break. For example, there's duplication of efforts, underserved areas, local actors are ignored, or there's unclarity about responsibilities among all the different community actors. There's also limited mechanisms to consult communities during planning phases, turning the planning, the RCC plannings, a lot of times not so relevant for the very hyper-local level when the emergency hits. And also this lack of mechanisms for consultation turns in limited understanding of community dynamics, making it very difficult for them to adapt planning, considering, for example, power dynamics or the access to information of certain groups, also language preferences or ethnic tensions in some of the contexts where we were developing the research. Or even specificities in access and decision-making by specific vulnerable groups. So there is rarely, in this regard, like a previous understanding of how information ecosystems work at the very community hyper-local level. And that makes it very difficult then after to tap on those learnings at the peak of the emergency, when everything needs to be very quickly. The response needs to be very quickly, and there's no time to properly understand and assess how to navigate those complex ecosystems. In terms of recommendations for this second set of findings, so we consider that collective data systems should be established in order to compile community data and inform all relevant information ecosystem actors on rumors, concerns, or questions, so they can actually respond to them from their very specific mandates or roles without having to centralize it all through key messages from RCCE actors, but they can actually work on autonomously on responding from, for example, their specific radio shows, or if we are talking about CSOs, community leaders also could inform their peers, etc., etc. We also consider that health information systems should incorporate social listening data when possible and work on the value beyond RCCE to adapt services. With this, obviously, we're not talking about collecting all and any kind of information and community data, but actually tapping on the community conversations in areas, for example, where it's difficult to access. Or where we have like vulnerable groups, as insights from into these conversations can provide very valuable information on service delivery gaps, barriers in access to services, or even relevant data for disease surveillance, ultimately also pointing at gaps in preparedness. And in terms of planning, we consider that a national plan should incorporate an information ecosystem lenses to identify best ways to connect, prepare, build capacity for actors, also conducting systematic assessment of information ecosystems, and contingency plans should incorporate also relevant actors with clear roles, responsibilities, and interaction lines. Now, up to here is the very first set of findings. And now we're arriving to my favorite part of the event, which is actually discussing a bit these important topics and hearing also from the experience and the insights from our guest speakers. So now I would like to ask this question to Sarah. So you've been leading the epidemic and the pandemic preparedness and response team within the WHE program, and you've been also working closely with the Infodemic unit, trying to understand trust in the context of health emergencies and epidemics. So from this perspective, we would like to ask you, what do you consider is the value of incorporating these information ecosystem lenses into national preparedness plans, and how do you think that can support the creation of further trust or trust building among all the different actors? Over to you.
Thank you. Thank you very much for the question and for the invitation, and congratulations on the research. Much of what I will reflect on is what you've covered in your findings and recommendations, and so I think that sends a very strong message. I think the impacts of, I work within the epidemic and pandemic department within WHO, but what we know is that all health emergencies, the impacts of health emergencies reach all people in all sectors. And so what we advocate for at WHO is for a multi-sectoral approach to epidemic and pandemic preparedness and prevention. This is, of course, exactly what you're advocating for here, and each unique information ecosystem at a local level or a national or global level is the result of multiple systems and multiple actors. So an information ecosystem lens applies or attempts to apply this holistic approach that's needed to engage these different sectors and stakeholders and actors, which is very much what we do across emergency preparedness and response. I think often there is all too much a risk that efforts in this space are focused on responding to misinformation in the context of emergencies, because that's often what's talked about the most. However, I think in this preparedness phase, there is much that needs to be done, first of all, to understand what information environments or ecosystems look like at a local level, so that we can do something about strengthening them for the time when there is an emergency response. And I wanted to briefly touch on two of the findings that you shared, which are two that are very close to the work that we've been doing within the Health Emergencies program, particularly when it comes to trust. The first was related to the health system stakeholders. We've seen that, as you said, healthcare workers are often very trusted voices within a community. They are the entry point for many individuals into the health system. They can influence the trajectory of an epidemic or a pandemic response because they have a role to play in the uptake of countermeasures such as vaccination, or even public health and social countermeasures such as physical distancing. However, often, and this is reflected in your findings, there is a lack of resources, time and support and capacities for healthcare workers to play that important role of ensuring that the science is translated, that they're responding to misinformation, and some of the other capacities that we would like to see among the healthcare workers. So I think there are significant opportunities to strengthen the role of healthcare workers, not only in this information exchange and science translation space, but also within the context of them building trust in the health system prior to and then during an emergency. So what does that mean? I think in terms of planning, well, it's a long-term view. I think the first thing is that these types of capacities and competencies need to be built into training curricula for healthcare workers. And then there needs to be ongoing support and training and capacitation during emergencies, because each emergency is different and will require a different response. The second one that's really important, I think, is the community level one. We were working very closely with faith-based health service providers and faith-based community organizations. And I think what we found was that, as you mentioned, there was a lack of formalized inclusion of these entities, both in the planning and in the response phase. So what we advocated for is that, and we try to showcase different models where faith partners were working very closely with national governments. This partnership was formalized either through a memorandum of understanding, and then they were built into specific projects, either around communication or around developing faith-sensitive health messaging, or delivery of social services, or delivery of healthcare. But the important point is that they were considered as experts within the community in preparedness and response, and the formalization of that expertise as it contributed towards national response ensured that everybody knew what the roles and responsibilities were, and it was a very equal partnership during the time of crisis. And that's a kind of partnership that you can't build during crisis. That has to be done in preparedness. And so I'd like to just reinforce what you spoke about with the community actors being much more inclusively involved in preparedness planning, so that they play a stronger role in support of national responses during an emergency. And so I think, the information ecosystem lens, it advocates, like I said, for a multi-stakeholder approach to preparedness. It's advocating for inclusiveness, formalized relationships, capacitated roles and responsibilities. And I think, these are many of the things that we promote across the emergency preparedness and response spectrum. And so thank you. It was really wonderful to read and listen to your findings.
Thanks, Sarah. It's actually great to see and confirm that this has also been felt on your side, and there's also ongoing efforts and initiatives to address those those gaps and challenges. I myself am also like always very interested in understanding the role of healthcare workers, as you were saying, community health workers, frontline workers that are actually there directly engaging with communities and have a very important and significant role to either to define, as you were saying, like even the response, or the trust of their patients. So it's great to see that they're being incorporated and there's being this link done, either if it's private health centers or faith-based organizations, or being part of the public health system, actually, that they're incorporated also into this kind of information response. Thanks for your contribution. And now I'm gonna jump into the second question for our colleague Michael Gubay, who's the project manager for Rooted in Trust project in South Sudan. He has also supported this research. So my question to you, Mike, is as leading these efforts, especially in South Sudan, in terms of the engagement with RCCE coordination platforms, and also supporting RCCE coordination at the national level, also the media sub-working group there. You've confirmed that this still take place very connected to the emergency stage, as we were sharing in our findings. And I wanted to ask you, what do you think that means for preparedness purposes when this coordination only takes place when there is an emergency and not before? How does that limited exchange of information before the emergency actually impact the work of information ecosystem actors, of media, of CSOs, and ultimately their ability to support prevention efforts? Over to you.
Okay, thank you, Rocio. My video is not working, so I have to try my best to get connected. So I hope that you will be hearing me. Yeah, most of the points that I'm going to say are connected because Sarah gave the background to all that also reflects what should happen in the coordination structures. I would like to say that this means a lot for preparedness, considering, the consequences of having a limited or absent coordination in the post-emergency period, pre or post-emergency period. As we know, there are a number of epidemic-prone diseases under surveillance where UN, WHO, Ministry of Health are partners reporting through the IDSR, or Integrated Disease Surveillance, reporting every time. And this means that, all information actors should also be aware, be informed to anticipate or provide information early and contribute to the prevention of diseases and reduction of the risk of transmission. This means exchanging information about this. All the information ecosystem actors should be aware about the priority disease under surveillance, what are the information that should be regularly be provided as part of the prevention, early detection, and also any reporting and notification of suspected cases. However, this lack of coordination if you see the trends in the past Ebola and the COVID, following the advent, there is a lot of effort that has been going on, and also a lot of learnings that have been drawn in. But in between, when the funding dwindles, or when at least the cases are going down or under control, the activities to coordination, regular meetings, others will be extended, postponed, and at times go down. Some of the subgroup meetings have not been conducted in this time, for example, for a year. Now, that means, the information exchange will be down, and it will make it very difficult for information actors to anticipate and fully get involved early and disseminate timely information that will be helpful for the communities to avoid any risk or prevent any diseases. Now, we know also tracking rumors, in addition to the ITSR, about any suspected disease, about anything, is one of the methodologies even WHO, the health system actors, are looking for in as a surveillance for early detection and reporting of epidemics. Now, but also information ecosystem actors should also collect regularly community feedback, rumors, misinformation, any concerns as part of what they do during the epidemic sittings or any threat or when any emergency is declared. That is a continuous activity that is going on. But in this period, IAL actors will not be able to continuously track rumors, detect or report suspected cases as the coordination activities are scaled down and they are not involved much. Now, another is these rumors which are persisting or which rumors high risk or whatever we call circulating rumors do not just pop up. These are ideas or information that have been circulating for some time. We need to know about how the community believes about the information gaps, any circulating rumors about the epidemic-prone disease or any emergencies before any outbreak. If we know, then we will continue providing education and all the information actors can exchange and make sure that effective communication among actors to address rumors timely is implemented. But this will not be happening, and this is one of the consequences of whenever in the post-emergency period there is a limited coordination. This is going to be a missed chance to address this in the early phases. Another point which I would like to is the negative effect on the capacity to respond effectively in case of any health emergency.
Just very quickly, because we are a bit late, so if you can wrap up your final ideas in 1 or 2 sentences.
Yeah, so this will be a missed chance for coordination, for making sure that all actors are part of the planning and decision making even before an emergency, as Sarah mentioned. Considering your second question, the limited exchange of information among actors definitely will impact their work, and I can say the consequences could be more pronounced on media, civil society organizations. They are not adjunct to public health emergency response organizations. Although the media and CSOs can play a good role in the prevention and during emergency, as I have said, that will make it difficult for them to effectively communicate and inform the public about risks and provide fact-checked information. Okay, thank you. This is
okay. Great, Dr. Mike. As always, it's very rich. Always what you share and full of details from your experience in Juba. So sorry that I had to cut. But we need to jump on, and I think you already mentioned a couple of very interesting points in terms of how the lack of coordination before the emergency, for example, prevents the early identification of rumors and misinformation that actually after are also mobilized during the emergency and can seriously hinder the response, among other issues. But I'm now going to jump into this second set of findings that talk about the 2 other elements, which are capacity and later we will see funding. So in terms of the common areas of concern that we are identified around capacity, there's 3 sub areas, let's say, or areas where gaps and challenges in capacity hinder the work of information ecosystem actors for preparedness, and these are communities. So lack of gaps and challenges in terms of communities informing RCC, media work, and health decision making. Gaps and challenges in terms of strengthening structures for misinformation response, and also gaps and challenges identified to ensure that technical health expertise reaches all stakeholders. So in terms of the first one, we identified that there's the dismantlement of social listening mechanisms after emergencies, or the narrow scope mechanisms on social listening that only focus on one single issue. ultimately lead to limited alert systems on gaps and needs in non-emergency times or in preparedness phases. And also the scarce capacity or the limited capacity of community actors to lead social listening in terms of data collection systems, analysis systems, and affects also their ability to effectively escalate to other levels of decision making within the community, for example, for relevant health system responders. This can turn into, for example, high-risk rumors running rampant among communities without a response, as Dr. Mike was saying before, driving into risky practices or becoming becoming mobilized during the emergency. This can also turn into increasing mistrust or tensions arising as questions are unanswered, or this can also become like a missed opportunity for humanitarian and health actors to create bridges with communities, making it difficult to have solid interactions once the emergency is taking place. We also identified that there are limited processes and systems in place to ensure community actors lead communication production and dissemination, impacting also the relevance of the communication and how it's adapted to the context during the emergency. We also identified, in terms of gaps and challenges in the structures for misinformation response, that there's a limited capacity and expertise to identify and respond to misinformation, especially as both Sarah and Dr. Mike were mentioning, as each context, each response, each disease response, it's also different, and it also needs like very targeted and specialized training or specialized capacity to respond to the misinformation and to the technical health gaps, for example, that can be among information ecosystem actors. So this is something that needs to be considered, especially when we're engaging with local media, with CSOs, and also health workers, as Sarah was mentioning. In terms of ensuring that technical health expertise reaches all stakeholders, there's inadequate process to ensure that the accurate health information reaches, for example, local media or CSOs. So, for example, in non-emergency times, there is limited access of media to local health experts. And also on the side of media, there's a deprioritization on covering health topics. So that makes it more difficult for them to build the necessary relations, the necessary partnerships and mechanisms for the exchange of information that allow media to quickly react when there is an emergency, or health also actors to quickly engage with trusted journalists and share the information. So, for example, as a journalist in Mali points out, when asking an NGO for information, they will say that they need to make a letter. We must make a request. But when there are emergencies, we cannot make a letter or wait until the response comes from Bamako, from Paris, or from the US. So when an NGO comes and intervenes in the health response, they should facilitate access to local journalists, because emergencies do not wait, and it is necessary to give real-time information to avoid disasters. This quote certainly illustrates this need to establish systems that allow real-time exchange of information, so it's contextualized, timely, and relevant. And finally, there is a lack of training also of local media, CSOs, and community leaders in health information, also impacting their ability to interpret complex health information. Then in terms of recommendations, we identified that technical experts and managers should be trained in the value of community engagement, as we said before, as an approach and not only as an activity. Community actors, and this is very important, should be supported to implement locally led social listening systems, so they can inform responders and health system structures about key areas for intervention during the preparedness phase. So this would require training volunteers or local staff, establishing systems for timely referral of concerns, and defining adequate protocols for information response, and closing the loop with communities on what they shared. And finally, it's important that partnerships with community information actors are prioritized to ensure that information is adapted to local languages, preferred formats, and contexts. So this means that actually local CSOs, local media, volunteer-based radios, for example, are the ones driving the communication, and it's not only about translating materials from HQ or from faraway offices. Also, these partnerships allow them these community actors to build not only the necessary capacity, but also to build the necessary infrastructure, to have the necessary equipment to maintain a continued service for the community. Finally, we considered that it's important that local RCCE focal points put in place mechanisms to update health workers regularly on the main rumor trends, so they're incorporated into the loop, and they know how they should respond or what is exactly the main concerns. And also, health system stakeholders should be trained in misinformation management and the importance of addressing concerns at an early stage. So this talks about like management roles, also technical roles to the very direct like frontline workers. And also, media should invest in systems that monitor misinformation circulating among audiences, establishing internal processes for fact-checking with systematic access to local health experts. And in terms of ensuring technical health expertise, we consider that it's essential that health system stakeholders and humanitarian organizations, for example, revise bureaucratic processes of external communication departments to increase media access to health experts, to be able to contextualize the information, the technical health information, and be able to ask questions if they have it. And finally, information ecosystem actors should be trained again in complex technical areas of public health. Finally, this is the last element that we wanted to share with you. The common areas of concern around funding for information ecosystem preparedness talk about inadequate resources to build systems for information ecosystem preparedness and national RCC capacities that can support prevention. There's also lack of resources for local actors to sustain health information provision as a means to build communities' preparedness and health literacy ahead of the emergency. And finally, there is an inadequate resources to ensure information exchange and coordination across information ecosystem actors. In terms of recommendations, we consider that it's important to have long-term funding prioritized to strengthen and maintain national RCC capacity, so it doesn't become like an afterthought during the emergency, but there's actually, again, like the adequate network established, the adequate relations, two-way communication channels, and all the different mechanisms to ensure that all the actors in the ecosystem can respond from their very unique mandate and role. Then we consider that more resources should be allocated to coordination to promote better those linkages that we've been talking about. Also, funds should be transferred to community actors to spearhead social listening, rumor tracking, and response continuously. And finally, longer-term funding for local media and CSOs actors must be considered so they can also build the necessary infrastructure. This is up to here for the second set of findings around capacity and funding. I know it's a lot of information, so now let's jump a bit into the concrete examples and illustrations that our guest speakers can bring to the conversation. Dr. Mike, I have a question for you around capacity, and I think we're also a bit, we have 4 minutes for this question. So I know that we know that as Internews in South Sudan and also other health partners have placed a lot of efforts on building capacity among media to respond to health misinformation and so they can be able also to adequately report on health. We've been doing so like through trainings on health journalism, also guiding media dialogues with local health experts and sustaining coordination of media sub-working groups. group. But how do you think all these different activities have played out for journalists? And do you think media are now more prepared to report adequately, to identify rumors, and to contextualize the information if there is a new disease outbreak or if there's a new health emergency? Over to you.
Thank you, Rocio, again. Definitely, I would like to say Ministry of Health, WHO, UNICEF, ICAP, and other many partners have in the Internews also a lot of efforts on building capacity among the media throughout the past 2, 3, 4 years, especially following the advent of COVID-19. And these capacity building efforts have definitely contributed to improved knowledge among journalists about the basics on epidemic-prone diseases, feedback collection, rumor and misinformation tracking, and health journalism and reporting on health. These are some of, for example, the feedbacks that we collected in our review meetings among story grantees, media outlets, and local radio stations. That, I mean, these all have contributed to produce quality content in local language, responding to community feedback. I mean, even in one project where we have been running, programs have been produced and disseminated with locally contextual information in 15 languages, like for a period of in the past 2 years. Now, regarding adequately to report, I think we can say they have used even innovative approach to make sure that sufficient and accurate information is available to the community. An example I can mention to you, one of our partners, Advanced Youth Radio, utilized a method called taking the radio to the community, in which the whole studio will be taken to a specific community and broadcast live, where there will be experts, where communities will be asking questions while it is live transmitted throughout Juba and the vicinities. And this program continuously goes every week, and that gives a confidence for many people to come and attend, ask questions, and get adequate information. The media roundtables in collaboration with WHO, Ministry of Health, UNICEF, and the dialogue sessions that we have conducted have also been very fruitful. Now media people know where to run and ask information and have a good relationship. There is a WhatsApp group led by Ministry of Health, UNICEF, and also the Union of Journalists. There are more than 100 journalists throughout the country where they are able to ask questions anytime and also get an information. Now, if thinking about forward, are they able to, adequately identify rumors, contextualize information, and report? I think I can say they are in a better position now, in general, compared to what we saw following the advent of COVID, which was very challenging time. Because they know now to collect feedback, rumors, and make sure that they can produce programs. Many programs have been produced, and we have been presenting to RCC, and many of our partners also been producing, and this is something good enough now. Also, there is collectively a feedback mechanism led by UNICEF and also Ministry of Health. Initially, we had also a unified rumor tracking tool where everybody can log in rumor from different all of the states. Now it is carried over and it is sustained. And also all the media houses, they do have the contact details of the RCC focal person at the state end. They have been interacting and they will know where to run if something happens and communicate. That is also another good position. The other good point is that following the discussion with the Union of South Sudan journalists, who are always saying that make sure that humanitarian health, other actors have the correct contact details of those operational radio stations and journalists reporting on health. Because at times funds are coming and there are people who have already not doing any work in journalism, health communication, are involved while leaving the others. So a detailed updated list using the Media Outlet Association, AMDIS, and which also have been given to humanitarian health actors, so communication will be more facilitated. Finally, I would like to point out all these efforts has contributed to improved relationship, which during our feedback with the media partners are saying now, between media, government, and community experts, and also involving experts during the programs is one of the areas. So considering all this, I can say they are more prepared than before, although this is a continuous process that requires a lot of continued effort. Thank you very much. This is what I have.
Thanks, Dr. Mike. Yeah, I think those are a lot of very valuable examples of how actually now media is better prepared. But as you were saying, it's a continuous effort. And I think this also brings me to the issue of like a systematic effort, right? And this leads me to the next question. Because a lot of times we see like standalone information interventions, and we don't think about like more systematic consideration. So I want to ask Sarah about that bigger picture or like a bigger story behind that piece of misinformation or information need. So for example, like results of a survey that can draw, for example, that in a remote area, there's a lack in parental awareness about vaccines. And we tend to think, as we were mentioning before, in terms of providing more information or changing behaviors or having like one big campaign or something like that. But actually, there's many factors that could be that could contribute to that situation. So, for example, community health systems not being adequately equipped to provide regular information, or for example, local radios not being connected with the efforts of vaccination teams, therefore like not having that conversation that Dr. Mike was talking about. So this brings us more from like shifting a bit from this individual behavior kind of intervention to more systems thinking. And because we want to explore more the idea of finding, how do you think, yeah, we can advocate to authorities and donors to build more on these systems that allow all actors to work collectively towards greater prevention, a bit as Dr. Mike was suggesting, like connecting all the dots in the ecosystem rather than driving just one big campaign. How do you think we could advocate for that? Over to you.
Thanks very much for the question, and I'm watching the time, so I'll try and be succinct. And in any case, the answer is not a very easy one to that question. I think collectively, as you said, we are seeing that priorities shift rapidly, and we're having a very hard time to keep preparedness for health emergencies on the agenda of policymakers and donors. I think the issue related to funding is complex because it's tied into political life cycles as well as to issues around accountability. It's much less easy to fund a systems approach to a project because it's then very difficult to delineate who was responsible for what at what point. And donors are often very interested in putting something in and getting something out, and the results are very clear to show. But when you have multiple actors working towards the same goal, accountability becomes very difficult both to manage but also to report on. And I think that's one of the most complex things that we need to navigate. And I think a lot of it is to do with the narratives that we build. We need to learn to speak the language of the donors and the funders and the policymakers. I think the language really needs to talk about outcomes and impact, and we know that, but it's also more importantly around the common vision and the role of preparedness, not just in terms of mitigating the impacts of a health emergency, but in terms of the system strengthening and the capacity building and the trust in the health system, and ultimately, of course, the trust in leadership and authority. And we also need to work very well, and this is at all levels, to reduce duplication and ensure that the arguments that we're presenting are a coherent argument, because often, as you say, it's a very crowded space and many people are doing the same things and not talking to each other. So there needs to be that kind of concerted effort for a coherent approach. And then something that I mentioned before is that point on formalization. I think it's great to say, oh, we're all part of an ecosystem and we're all contributing in some way or another. But unless those roles and responsibilities are clarified and those contributions are kind of quantified and formalized, not in a way that's punitive at all, but in a way that respects the mandate and the role of each individual contributor, it's much easier then to talk about funding and accountability. And of course, none of this would be possible without, very strong leadership, which, it all hinges on that, I think, eventually. Thanks for the question.
Thanks so much, Sarah. I know it was a difficult question, but you've succeeded. And I think you mentioned a lot of important points, especially like having a very strong leadership and who can actually drive those conversations on longer term interventions or programs that can actually help to create these systems. So thanks so much, both of you, Dr. Mike and Sarah, for taking part in this conversation today. I don't know if we have like any questions. We are coming closer to the end, and our final conclusion and a final wrap up is we would like to reflect on what was shared. And also sharing some final points that we hope serves also as a roadmap to think how we can build a stronger information ecosystem. We obviously understand that this is open also for collective thinking, brainstorming on how we can work towards better prepare information actors. So we have a couple of points. We consider that all actors need to have access to locally relevant, timely and actionable information. All actors need to have capacity that encourages critical evaluation and use of information. All actors have access to resources or mechanisms to verify information and contextualize it. They all have the ability, capacity, and resources to plan and implement before and as the emergency stages evolve. And finally, all actors can inform other responsible actors about their needs, concerns, questions, and ideas. So this is up to here. Now we would love to hear you. If you have any questions, any comments for us, for Sarah, for Dr. Mike. Otherwise, I think we're also closer to the time. Is there any question? Okay, so we don't see any questions in the chat. So we will leave it here. Thanks so much for bearing with us. And please get in touch if you have any final comments or you'd like to discuss further. Thanks so much to our guest speakers, and thank you all for attending today. Bye.
Thank you. Take care. Bye.
Thank you. Bye. Thank you. Bye.
Thank you so much.